Hello, my name is Elliot Harmon. I'm a Wayne State resident, and I'm presenting Is the ultrasound guided out-of-plane adductor canal continuous catheter placement superior to in-plane placement in total knee arthroplasty? First, a little background. Often we'll use an adductor canal nerve block after total knee arthroplasty to help with pain relief. We can either do these as single shot, which is just one injection, which will help for 12 to 24 hours, or we can leave a catheter in place afterwards, which can give patients pain relief for up to 5 days. So pain after total knee arthroplasty is important. These joints are pretty osteoarthritic beforehand, and the surgical repair of them requires a lot of bone cuts and a very large incision. But physical therapy afterwards is really important. It helps improve long-term joint range of motion and also helps reduce pain afterwards. But the way that we can help patients get back to physical therapy is by an understanding of our nerve anatomy. So there are some branches that innervate the joint from the obturator nerves, some from the sciatic nerves, but most importantly for this lecture, most of the branches come from the femoral and therefore sciatic nerve. The way that we manage to block these nerves is by placing a perineural catheter. We'll use a needle to get through the skin and subcutaneous tissue, and then we can either inject local anesthetic directly, or we can place a catheter through the needle, which allows us to infiltrate the space around the nerve for anywhere up to 5 days. In order to place that needle and the catheter, we'll use ultrasound. Ultrasound's pretty helpful. It decreases the amount of time it takes to do the block and also decreases the amount of complications during block placement. Techniques do vary, and that's the whole source of this study. So perineural catheters, as I said, are mentioned, are very helpful for postoperative pain management, and early physical therapy is our goal in order to decrease hospital lengths of stay and increase long-term knee range of motion. But we want to be able to allow patients to both participate in physical therapy and also have effective pain management throughout physical therapy. So when using ultrasound for perineural catheter placement, we can either view the nerve in short axis, as shown in picture A, which will result in the image that you see in B. So you'll see that nerve in cross section, which will just be a small circle, or you can view it in long axis. Using long axis, it'll generate the image in D, where you see the nerve coming across the whole screen. Now, a few pretty helpful studies looking at femoral nerve catheter placement have shown that viewing the nerve in short axis both results in shorter time for block placement and fewer arterial punctures. So then we can think about how we're going to look at the needle itself. We can either look at the needle in plane with the ultrasound beam or out of plane with the ultrasound beam. Now, the presumption here is that we're always looking at the nerve in short axis, and the question is just how we're going to have the needle approach the nerve. So looking at it in plane, you're going to be able to view the entire needle, as you see over on the left-hand side of that picture. But when you finally thread the catheter into that space, you're only going to have the very tip of the catheter in proximity to the nerve. Whereas when you use the out-of-plane approach, the catheter is going to end up placed parallel to the nerve, which means that you're going to have more catheter that can come in contact with the nerve, which theoretically will allow it to have greater margin of error for any possible dislodgement from motion. The idea is just that the out-of-plane approach is going to put the catheter parallel to the nerve, and by being parallel to the nerve, that it'll be more resilient to any motion that occurs, such as that during physical therapy. Our methods: 100 patients randomly assigned by the computer to the in-plane versus out-of-plane approach. After a few patient exclusions, we had 39 in the inpatient and 30 in the outpatient. The only difference between these two groups is the needle placement, whether it's in-plane versus out-of-plane, but the nerve is always viewed in short axis. Preoperative medications and intraoperative medications were standardized, and the primary outcomes we looked at were length of stay, total opioid consumption, average postoperative pain score, and need for catheter replacement. We also looked at secondary outcomes like total ondansetron usage or acetaminophen consumption and any other antiemetic drugs that were used. In conclusion, we didn't see any differences between these two. So pre and postoperative pain scores, length of stay, age, gender, drug usage, all were without any significant difference between the two groups. And there were no catheter replacements that were required in either group during the study. Here's a little box and whisker plots in order to show that for all these drug usages and pain scores that everything was no significant differences. All of these drugs were available on a PRN basis, so all patients can ask for them as they need, and that's how we kind of evaluated the efficacy of these blocks. So both techniques can therefore be used interchangeably for analgesia after these total knee arthroplasties. In the past, we've seen some studies that have shown that, somewhere between 15 and 25% of catheters will end up dislodged. So we're highly incentivized to look for techniques that minimize any dislodgement. We've seen similar studies as this one, looking at femoral nerves and interscalene nerves, looking at the in-plane versus out-of-plane approaches, and they have also found similar results. So it's important for us to now know that for the adductor canal as well, that it isn't as important the way that you orient your needle to the ultrasound probe. It's really just finding a way that you feel comfortable with. And I think most importantly for this conference, this is highly applicable to educational hospitals. So residents of varying experience, PGY 2, 3, 4, all placed these catheters. They were all trained how to do it, and everybody got adequate anesthesia. A few limitations. We did use single orifice catheters. Catheters come in a variety of different forms. You can have either a hole at the distal tip, or you can have fenestrations anywhere from the distal tip up to 5 centimeters proximal. And maybe we'll just say that these results are most applicable to single orifice catheters, but that it's worth looking into whether or not different types of catheters would have similar results. And as I mentioned earlier, knee pain is not mediated just by the femoral and saphenous nerve, but also by the obturator and sciatic nerve. So although the majority of the innervation comes from the femoral nerve, we therefore chose only to block its branch, and we did not, in order to avoid any confounding results, block any of the other branches. And we were a single center as well. I've got, thanks for your time, and I hope we all learned something.